Good morning. Welcome to the 2017 Maine Health Management Coalition and Maine Medical Association Symposium. My name is Michael DeLorenzo. I am the interim, and I stress the word interim, CEO of the Maine Health Management Coalition. We have a fantastic program starting with the Keynote after reading Elisabeth Rosenthal's book a while ago and talking to her last night at some length at dinner. She is the ideal keynote, I think, for the new Maine Health Management Coalition, so we're so pleased she could come. There's just incredible alignment in what she's talking about and what some of the solutions are and what we know we need to do now. We are looking for leadership to solve some of these problems. As always, we want to thank the Maine Medical Association for partnering with us on the annual symposium, and I want to thank in particular also Trevor Putnoki. Trevor does an amazing job working with the Maine Medical Association and pulling this together. This is largely his work, so thank you very much, Trevor. Because the Maine Health Management Coalition has been going through some transitions and folks are asking kind of what's up, I want to just take a couple seconds to review a few things with you, but I do not want to take any of Elisabeth Rosenthal's time. As many of you know, we have been going through a lot of changes over the past year, and the symposium program, I think, reflects our new direction really well. There's some candid talk about the issues, immediately moving onto some specific actions that engaged purchasers, and I want to stress that, engaged purchasers need to take, and if we're going to make any real progress on the cost issues, and the cost issues can't be ignored any longer, and so the question is, where is the leadership going to come from to really address them and do some of that hard work? Following the keynote, Charles Lawton is going to bring the economic issues to the state level and make it a bit more personal for us in Maine. Who saw Charles Lawton's article in the Portland Press-Herald about 10 days ago? Okay, that is, you know, he called out Maine for being number one, and we always love to be number one. But who knows what Maine is number one in that he referred to? The portion of our personal spend that goes to health care. We are number one in the nation for the portion of our personal spend that goes to health care. Okay, clearly unsustainable. Well, part of the issue is the rate of economic growth in the state. The problem is not that health care spend is okay and we just don't have enough money, which was famously said on this stage about 2 or 3 years ago. Believe it or not. The fact is, it is not a denominator problem. We have to do something about the numerator, which is, I have a background in analytics, but we have to do something about the cost, which is cost of health care. What we do know is the status quo way of buying health care is unsustainable in Maine and nationally, and we need some leadership to drive to some solutions. So what are some opportunities that we're going to be looking at in the coalition? Some things that are on the program. One example is our program on RX, or pharmacy group purchasing for members, complete PBM transparency, and making sure rebates get passed through to the purchasers. Too much money on the table for the purchasers. This is a proven approach that folks have used around the country. We're well on our way to doing this, and we think it's going to be a success. This is a good example of the kinds of things the new coalition is going to do to create real value for its members, demonstrable value. Marcia Peterson from Washington State is going to talk about bundled payments, including a Center for Excellence for knee and hip replacements. This is based on work of a true multi-stakeholder collaborative approach. We are still full in on multi-stakeholder collaboration, but we're going to do it from a position of coming to the table with some things we need to accomplish and not backing off from that, and willing to work with folks who are willing to partner on moving towards value-based purchasing. The nice thing, it's interesting in Washington State, and you'll hear about this, and I encourage you to go to the talk. In Washington State, they formed something called the BRE Collaborative, and it was established by the Washington State Legislature. And the whole value-based, multi-stakeholder approach aligns perfectly with our view of real collaboration, willing to work with providers who want to engage with us in creating a new way forward. So these are just a few examples of what we have for you today. There are other great breakouts on benefit design, quality and patient safety, update on legal, legislative, and regulatory issues, and so forth. But I wanted to highlight these few topics. I wanted to call them out, which makes it clear what the coalition is up to. Next year, the title of the symposium will be slightly different because we will no longer be called the Maine Health Management Coalition. We are going to rebrand the coalition at the end of the year with a new name and other things, so stay tuned. So with that, I want to ask Dr. Charles Padavina to come up. He is president of the Maine Medical Association. He's going to say a few words. In addition to being the president of the MMA, Dr. Padavina is an ER physician in Bangor at St. Joe's.
Thanks, Mike. Well, good morning, everyone. I am the president of the Maine Medical Association and would like to extend the Maine Medical Association's warm welcome to all of you for attending today and for supporting this great activity. It's really nice to be in this beautiful facility. I hadn't been in here before. We're also equally enthusiastic to be partnering with the Maine Health Management Coalition, and whatever you're going to call it after the end of the year, because this meeting is so much better since we combined efforts to make it one meeting. And it's just very gratifying to see how it's succeeding. We certainly couldn't produce an event like this on registration fees alone, so I want to thank our sponsors, which include Spectrum Healthcare Partners, the law firm of Norman Hansen and Detroit, Aetna, Anthem, Harvard Pilgrim, Novo Nordisk, and Johnson & Johnson Healthcare Systems. Just a few logistical notes. If people need CME credit, broker or HRCI credits, you should see Dee Carey at the registration desk. Lunch will be on the second floor at the top of the stairs, and the breakout rooms up there are also available for lunch. There will be a break following the keynote, which will give people an opportunity to ask Dr. Rosenthal to sign her book. And we also encourage you to visit our sponsors, many of whom are exhibiting out in the outside the auditorium. And I'd also like to thank Trevor, as well as Sue Crane and everybody else for their hard work in putting this event together. Thank you very much, and Mike.
Okay, I'd like to ask Dan Landry to come up, but we want to thank Spectrum Medical Group for sponsoring the keynote. Dr. Dan Landry is a pediatric cardiac anesthesiologist, and if that doesn't sound like specialization, I'm not sure what does. I actually think he has a degree in engineering as well, and he is president and chairman of the board of the Spectrum Medical Group. And just because he doesn't have a full-time day job, he is currently getting an advanced degree in healthcare economics from the London School of Economics. Is that correct? Yeah. So please come up and introduce Elisabeth.
So I have to correct Mike, because we just underwent a rebranding and we are no longer Spectrum Medical Group, but Spectrum Healthcare Partners. You'll see what this means, Mike, in the future when you rebrand, how difficult that is. So as Mike said, I'm Dan Landry, and for most of my career I've been a pediatric anesthesiologist and feel fortunate to have had the opportunity to care for so many children and young adults here in Maine. I now serve as president and chairman of the board of Spectrum Healthcare Partners, which is a large physician-owned multi-specialty practice group that serves the Maine and much of New England. I'm very grateful to have this opportunity to introduce Dr. Rosenthal. I'm going to go off script for a minute. My communications person is going to panic, but Dr. Rosenthal doesn't realize this, but she is, some of us are more excited to have her here than if it were Mick Jagger and the Rolling Stones. She is a rock star in healthcare and healthcare policy. And I want you to think about where we are today and who sponsored her to get here and who's out in that lobby. Maine Medical Association, Spectrum Healthcare Partners, which is all specialty physicians. Did I say Maine Medical Association? Insurance companies, the people that are benefiting most from the flagrant costs in the healthcare system. And to me, that means we all realize that it's not about the revenue we bring in it anymore. It's about the sovereignty of our country and about a healthcare system for our children. That's what's at stake now. It's not about my W-2 anymore. It's about my kids. And I think Dr. Rosenthal deserves a lot of credit for that pivot. So now I'm going to go into my more prepared remarks. And think about who is not sponsoring this. So Dr. Rosenthal attended Harvard Medical School. She went on to an internal medicine residency program at New York Hospital, Cornell Medical Center. Following her residency, she worked as an ER physician for a number of years, but then did a huge pivot into journalism. She worked for many years for the New York Times, writing groundbreaking pieces on cost of healthcare, and what I learned last night, did reporting on things vastly different than healthcare, which I think she's going to talk about, so I won't spoil that. She's been a Poynter Fellow at Yale, Ferris Visiting Professor at Princeton, and an adjunct professor at Columbia University. Now, if that's not impressive, right? She's contributed to or appeared on many of the media that we use every day, including NPR, PBS, contributed to the Washington Post, and as we know, the New York Times. She's now editor-in-chief of the Kaiser Health News. When her book first came out, In American Sickness, which I think everybody is receiving today, which if you haven't read, you have to, became available in April, and I think I read about it in the Wall Street Journal before it was published, I'm not certain, but I was looking forward to it, and as soon as it came out, I went out and got a copy. And as she started in on the challenges of healthcare today, I, like everybody else, had my pitchfork. Let's get that angry mob together and find out who's to blame for this problem that we call healthcare. The hospitals, absolutely, right? The insurance carriers, let's get them. Big pharma, absolutely, they're part of the problem. And then we started reading about the physicians. We own some ASCs, and I was like, wait a minute, that's not the problem, right? But she didn't pull any punches. And if you read that book with any honesty, you realize we are all to blame for what we have created. And I take equal blame with everybody else, but also the responsibility to fix that. Her book was uncomfortable to read, but also inspiring. Inspiring that myself and my organization can work with other healthcare systems and providers to do something to change the narrative. This book was so important when it first came out, I bought a copy for every executive in my organization and all the board members. Her book highlights the massive challenges we face as a country and that no single entity has a solution. And we often hear people come forward and say, this is a solution, that's the solution. There is no single solution. It's multi-pronged. It's a problem that we all share, and we have to take responsibility in the solution, everybody in this room. Dr. Rosenthal's book certainly stoked an already smoldering debate on the crisis that is healthcare costs. She's clear that doing nothing is not an option. We all bear responsibility for the system we've created, and we must be the catalyst for its reform. It's clear, this is an understatement, that our representatives in Congress are not going to help fix this. So it really is up to us. Change is only going to come about with influential individuals like Dr. Rosenthal speaking out, which she has, and each of us now taking an active role in the solution to this crisis. So please join me in welcoming Dr. Rosenthal here to Maine and to our symposium.
Sorry, everyone. I'm hobbling a bit from a knee injury for a few weeks ago. Anyway, it's really great to be here, and I think, wow, great timing for scheduling this conference. Just 10 days ago, Congress failed to pass Graham Cassidy. Thank you, Senator Collins. Good work, Maine. And now we all have the opportunity to act in the states, in our hospitals, in our practices, and patients as you seek out your medical care. There's hope and there are opportunities that we can act to make this system work better, because it's hard to imagine it working any worse. And that was the point, really, of, or where I came away from writing An American Sickness, which was a year-long work for me. It was a passion. I always called it my third child, because I wouldn't have done it if my kids didn't go away to college right then. But it was a fascinating exploration. And at the end of it, I came away thinking we all can and should act. The book was going to be called Your Money or Your Life. But instead, I just had the last sentence be, given the false choice of your money or your life, it's time to take a stand for the latter. And I also wanted to end the book with a quote from Winston Churchill, which is overused, so my editor yanked it, but it still says a lot and says where we are, which was, you can always count on Americans to do the right thing after they've tried everything else, which... and that's where I think we are right now. We have tried everything else, and certainly the Graham Cassidy bill included much of everything else. So anyway, I'm not sure how I get to the beginning of the PowerPoint. Advance the slide. There we go. Oops. Oh, back. Sorry. Now I want to go back.
Previous, on the right-hand side where it says next on your screen.
Yeah, previous, okay. Now, sorry. Now my back. There we go. Okay, so first off, I'm just going to talk for a bit about how this book came about and my history, which is kind of unusual. Ironically, I left the practice of medicine in the 1990s to write at the New York Times. And the reason was I was practicing in an emergency room. I actually loved what I was doing, but a lot of the patients in the emergency room were having troubles that were system problems, not medical problems, really. So I'd been doing a lot of freelance writing on the side, and there was a thing called the Clinton Health Reform, remember that? And the Times said, would you like to come and cover this full time? I did, assuming that I would do that for a year, it would pass, and I would go back to practicing medicine. And of course, neither thing happened. I got a little bit jaded with this whole health reform policy stuff, and the Times offered me a job as a foreign correspondent. So I did a kind of 10-year hiatus doing foreign coverage, although when I was in China, it happened to be the time of AIDS and SARS and bird flu, so I ended up doing a lot of medical coverage. And then I got hooked on international environment, which was and is really a passion of mine as well. I was based for that stint in a number of different countries, and so I experienced a number of different health systems, which help explain how this book came to be. And now I'm going to sound accident-prone as when I hobbled up the steps, but I'm a jogger and I sometimes fall, so anyway. I broke a wrist in Stockholm. went to see, through the Times, the fanciest orthopedist in Stockholm, who looked at my wrist, x-rayed it, casted it, and apologized profusely for charging $400, right? I got stitches at Gemelli Hospital in my forehead. Like I said, I've been running a long time, so. And I went to the Gemelli because it's the Pope's hospital, and I thought, well, if I'm going to go to an emergency room, I might as well go where the Pope goes. An ER doctor, and it was pretty barren, that stitched up my forehead, and again, charged me 112 euros, I still remember, with profound apologies. And so I was kind of used to that being the norm. When I returned to the U.S. in about 2007, I was shocked to see how expensive healthcare had become. When I was a resident, there was this brand new antibiotic called Augmentin, which maybe cost $30 for a prescription. Everyone was like, oh my God, that's really expensive. And I came back, and one of my kids had an ear infection, and the same antibiotic was like $120. And I'm thinking, wait, what? This is off patent now. What's the point? Why is this going on? My little asthma inhaler that I'd used for running, which was $10 before I left, I came back, went to fill a prescription, and it was $80 or $90, and I was like, what's going on here? This is the same old stuff. It's off patent. No, it's not off patent anymore because the CFC propellant that was in it had to be taken out, and so the FDA allowed the drug with a new propellant to come out as a patented drug, even though the medicine part of it was exactly the same. So it's not really a new patent. And also there was this little counter on the back, which I get it, it's convenient, but it's not worth 10 times the price, to me at least. So anyway, more important, and this is where I came back at 52, and I needed my first, that entree into middle age, my first screening colonoscopy. So I bet not many book talks start with that, but here we go. I knew, from all these signals, I knew that medicine had gotten really, really expensive. So I asked the New York Times, well, how can I get this in network? Because, of course, thinking that way, my worry was expensive for me, right? I wasn't thinking well, what's it going to cost the system? And they said, oh, you just have to go somewhere in network, and here's a list of places that'll do it in network in New York. So fine, on the list was Memorial Sloan Kettering Cancer Center, and I think, why not go to their screening clinic? This is perfect. So I sign up. I'm a little surprised because in med school I'd seen a screening colonoscopy in a doctor's office, but hey, I trained partly at Memorial. And I know I'm getting a wristband, I'm getting a bonnet, I'm being admitted, I'm being rolled into an operating room, and there are anesthesiologists and tons of nurses in scrubs, and I'm like, whoa, something's wrong here. And my propofol stopped my worries. I woke up clean bill of colon health and happy. But then about a month later, I got the explanation of benefits, which showed that Memorial Sloan Kettering, a place that I respect very, very much, had charged $12,000 for that screening colonoscopy in the operating room. And my insurer, who I was grateful for at that very moment, to a point, sent me one of those happy explanation of benefits that says, they charged $12,000, we paid $9,000, too much, right? And good news, your copay is $0. So I guess a lot of people would have thought, whew, I dodged a bullet there. But I was really upset because I knew that a country that charges $12,000 or $9,000 for screening colonoscopy is going to end up exactly where we are today. So when the ACA was approaching enactment, my editor at the New York Times, Dean Baquet, said, why don't you come back and cover healthcare? Stop flitting around the world covering environment stuff. This is more important. And I said, I don't want to cover healthcare if I can't cover pricing. I want to know why American medicine is so expensive, what's driving the prices, and what we can do about it. So he gave me the green light to do a 2-year series called Pain Till It Hurts, which I'm extremely proud of. Looking at the ordinary medical experiences that most of us have, I didn't want to do one of those articles about the $1 million cancer treatment or the you know, the hugely expensive drug. I wanted to talk about experiences that every American could relate to. So what did we do? We started with colonoscopy. Now you know why. Much to my photo editor's horror, I should say. But she managed. Then we went to stitches, asthma inhalers, insulin for diabetes. We just did all the ordinary things, echocardiograms that people, our readers were likely to say, yeah, I had that, or I know someone who had that, so why does it cost so much? And we kind of dug in to those price points. We also, it's hard to believe in 2017, but this was kind of the early days of social media in newspapers, so we decided let's just ask people about their own experience. So we put up comment boxes on each article. We very quickly had over 10,000 comments on the series. That I like to remind people is more than Nate Silver on Election Day. So, you know, people were passionate about this, and I always would tell people, you know, it's worth reading those comments because they're kind of a catalog of all the different ways that our health system is failing people. And very few of them complained about the medical care. They liked their doctors, they were grateful for the care, but they hated the system in which it was delivered. So when you know, at some point when you're a series reporter, it's time for the series to end. It was going on for 2 years already, and my editor said, okay, what are you going to do next? I somewhat half-heartedly wrote up a proposal for a project on infrastructure, and then decided I have these 10,000 stories. I want to know more. I know about these individual procedures. I want to really look at the system, so I took a book leave, and that became An American Sickness, the book you're seeing up there. And I really wanted to dig into the why of the system. And I learned a tremendous amount from calling many of those 10,000 people. And I should point out, many of them were physicians, healthcare administrators, worked in pharma to tell what they had seen and to tell what was expected of them, to talk about things that made them really uncomfortable. And what I came to see, and that's kind of the theme of the first part of the book, is how since the time I practiced medicine, my dad was a doctor too, so I've watched this for a long time, how business interests came to kind of hijack this caring endeavor I'd cherished and my family had cherished all these years. My dad was a pediatric hematologist. And how the metrics of business, which are things like efficiency, return on investment, revenue generation, are just so, you know, there's a little area where they intersect with the values of medicine, and that's not to say medicine wasn't hugely inefficient before and couldn't have been made more efficient, but efficiency is only a medical value to a point. So I think we've got to move back to a system that incorporates those medical values, and where there's good return on investment, great, that's fine, but medical values have to be the starting point of our medical system. You know, so many times as a reporter I'd written about patient-centered evidence-based healthcare as like an innovation, and at some point when I was writing the book and had more time to think, I sat back and said, whoa, wait a second, like, patient-centered, evidence-based healthcare. What other kind of healthcare could there be? Isn't that what medicine is? So, you know, and that's the problem. We've really moved away from that. So everyone in this room knows, you know, we still have tens of millions of people uninsured. We can praise a lot of things about the ACA, and we saw how they helped bring down some of the Republican proposals, the way it gave insurance to people with pre-existing conditions, took away lifetime caps, and kind of established this notion that people should have some kind of protection from medical costs. What it didn't do is directly face costs and prices, and until we do that, I think none of the plans will work. And that's what you kept seeing in these Republican plans, which were faulted for a number of reasons, but in the end what brought them down from the political side is those CBO numbers just didn't add up because we pay way too much for health care. And I think on the political side for individuals, what brought them down is that people didn't like this idea that people with pre-existing conditions could end up not covered. We heard about how the stress that medical costs puts on people here in Maine. And we all know we pay nearly 20% of our GDP on health care, and that's going up. We already pay 2 to 3 times as much for health care as people in other countries without better results. Now that I'm at the Kaiser Family Foundation, we've looked at some of the numbers, and more than 20% of people with insurance under the age of 65 said they had problems paying for medical bills. So I think we really are at a tipping point, and we need to do something. We consider exorbitant medical bills the burden of being American, and our insurers pay them, and our employers so far have mostly tolerated them, and that's what this book and this talk is about. So people from other countries, and you can read about some of them in the book. There are a number of people I now have met who I call healthcare refugees, who have left the U.S. because they had a chronic condition and they knew they couldn't afford to have it treated here. We're talking to several people who were injured in the massacre in Las Vegas. They're Canadians, and they're stuck in this high-priced system, and they can't wait to get home. That's their big issue now. So people from other countries ask, why do you put up with this? And I don't have a good answer. We just heard about studying at LSE. I'm sure you get the same question. Why do Americans put up with this? There's really no good answer. I heard from one guy who didn't make it into the book, a German guy who was living in San Francisco for a few months on a business project, got in a minor bike crash, saw an ambulance, someone called an ambulance. He wasn't that badly hurt, but he thought, as he would in Germany, sure, I'll take an ambulance to the hospital. Was taken to San Francisco General. They said the nurse saw him come in an ambulance, so called the trauma team to come down, even though he wasn't badly injured. She was doing what she was supposed to do. 4 hours later, he was discharged. He walked out, had a bunch of bumps and bruises. That public hospital charged him a $10,000 trauma team activation fee. There is no one in the medical profession that would say, yeah, this is a good thing. And I don't think there's anyone even in hospital management who would say this is a good thing, except maybe the guy who runs, or the woman who runs the accounting department, who would see it as good money. So the point of this book is we don't have to put up with this. There are many ways to make it better. Thankfully, most of them don't require any action from Congress, so now I think we're all pretty clear we're not going to get that. So it's time for us to do what we can. So the first step to me is always to try and understand how we got to this place, because it's pretty mystifying to me, and that's the first half of the book I tried to do that. So I'm going to take you on a quick ride through it for those of you who haven't read it and introduce you to some of the characters. Again, these are all characters who came to me through social media, so I didn't go out looking for people who had problems. They had problems that the health system couldn't or didn't fix. Okay. These are the book starts with some tongue-in-cheek rules of the economic market, of the healthcare market, and they're somewhat tongue-in-cheek, but as I show you these examples, think about where I'm coming from. I'm not saying this is medically a good thing, but if you're thinking of what makes financial sense, these rules are absolutely true, and you'll see examples of them as we go through some of the patients. A lifetime of treatment is preferable to a cure. That's the one everyone reacts to, and they say, no one wants that, no one wants that. True, no one will say they want that. It's obviously absurd, but think about it with respect to type 1 diabetes. There's a woman in the book who had a proposed cure for type 1 diabetes. Now, I don't know if it will work or not. She's a researcher at Harvard, but she cannot get funding for that project except by crowdsourcing, because all of the funders of diabetes research in this country, they're mostly pharma companies that make a lot of money off of treating pharma. And when she came to them for funding, she said, they told her, it's a really good idea, but why would we fund this? We've got this billion-dollar industry now. It's just not what we do. So another one, again, defying all rules. Economies of scale don't translate to lower prices. We see this over and over again. In flat screen TVs, prices have come down. With medical consolidation, all we've seen is prices go up. When I checked on what a colonoscopy costs in Germany now, it's $300 to $500. When I checked on what an echocardiogram costs in Japan, it's about $100 to $150. In the US, it'll be anywhere between $1,000 and $10,000. So that's kind of the good news, is these things are so absurd and the price differentials are so high that there've got to be a lot of low-hanging fruit, things we can do. This is the first person I wanted to introduce you to. His name is Dr. Jeffrey Kivy. He's a teacher at New York Stuyvesant High School. He has a degree in chemistry, and he worked for Abbott Labs for a number of years before he turned to a teaching career. He has something called psoriatic arthritis. And Dr. Kivy contacted me because he was getting his infusions of Remicade, which had changed. I mean, again, people really were grateful for what they'd gotten. He was getting infusions of Remicade every 6 weeks for psoriatic arthritis. It had literally changed his life. He was teaching, he was able to stand. One of my kids went to Stuyvesant. The escalators are always broken. You're walking up and down stairs a lot. And he was able to do that. So he was getting those infusions for $19,000 a pop at a downtown hospital in New York, which, you know, at first pass sounds really, really expensive, but we've all been, part of it is we've all been so kind of inured to high costs that we go, okay, $19,000 for an infusion, maybe that makes sense. So he didn't balk at that. But then his rheumatologist moved uptown to NYU, and his first infusion there was billed at $110,000. Now, it was, he didn't pay any of it. He's a New York State teacher. He has really good insurance. It was the same infusion, same drug. The only thing he noted that was different is at NYU, the infusion rooms had free internet and cookies and, you know, a little refrigerator with drinks or you know, free drinks. And he noted that those were really expensive cookies. So Dr. Kivy, being, like many of the patients I encounter, a bit of a pit bull about this, went back to NYU and said, why? You know, this is the same drug I've always had. And then when they didn't give him any kind of reasonable answer, he called me. And I called them as well and said, why $110,000? And I can't tell you the number of weird explanations I got, like he's fat, you know, he gets a high dose, you know, we call back our patients the next day. I mean, none of which justified a rise from 19,000 to 110,000. But his bigger argument was really, and by the way, I checked how much this hospital pays to buy Remicade through the 340B program, which they use. It's about $600 for his dose. So big markup there. They're making a lot of money each time Dr. Kivy goes. But the thing that bothered him most was that his insurer paid for this. And by proxy, I, as a New York State resident, paid for it. And so he was really angry. And so he went to his insurer and said, why are you paying this? And again, he gave up in the end, but he made about 20 different phone calls, called me to write about it. In the end, you know, rule number 10, the price of anything will rise to what the market will bear. His sad, somewhat sad after story is he decided just in anger that he would not take Remicade anymore, that he didn't want to be part of this game. And he changed to something called Enbrel, which he could give himself at home. It didn't work nearly as well. And when he tried to get back on Remicade, then and only then his insurer said, it's too expensive, we're not going to cover it. So poor Dr. Kivy, he said, told me recently I'll probably have to sue to get back on that again. Next one, I like to tell the story of some of our hospitals. I'm sad that none of them are here, but maybe you can relate this back. I wanted to know how hospitals became the kind of entities that we see today. So one person who called me about the research I was doing was a guy named Dr. Frank McCullough, who's a pediatrician, wonderful guy who just retired from a long career at Providence Medical Center in Portland. And he wanted to tell me what he'd seen during his career, how he'd watched it go from a hospital that he felt really good about, that allowed him to feel a sense of mission and caring, to one that he just didn't recognize anymore. So I went back and looked. He described how when he started, There were nuns in the emergency room, so I looked back at the foundational myth of of Providence Health System, which is now, I think, the second biggest health system in the country, or second biggest Catholic health system in the country. It was begun by a group of sisters from an order called the Sisters of Mercy in Montreal, who came out to the Wild West to establish healthcare in the American West. I like it that the Sisters of Mercy have another operation in Valparaiso, Chile, because their first attempt to come to the West Coast, their navigation was off and they ended up in South America. So anyway, but what Dr. McCullough told me over many hours was watching the culture of health get diluted in a hospital he loved. And he described, it was a succession and a slow succession. First, the nuns went away. Then there were courses on billing. There were courses on coding. And there were courses on Press Ganey scores and how to get good reviews, what you had to do, or he called it charm school. They were told they were no longer employed, that they had to set up a separate corporation and subcontract their services back to the hospital, that the hospital didn't want to take on their malpractice risk. And it was just kind of one thing after another on this poor guy who was working mostly in the outpatient clinics just trying to do his job. But the thing that bothered him most was the building, and the building and more building and more building and more building, so that what he recognized, the hospital he was working at the end of his career had marbled fountains with jumping salmon and, good art, but none of the values that really mattered to him. So I want to show you next, and I'm going to move quickly here. This is a quiz. I can send out the links. We did this for the New York Times. It's called, "Is this a hospital or a hotel?" When people tell me our hospital is really struggling, and that's not to say there aren't many who are struggling, the first thing I tell them in most cities is go into the lobby and order a latte and tell me who's struggling. So anyway, you can take this. It will tell you if you're right or wrong. I don't remember. Maybe this is a hospital. Yeah, it's a children's hospital. Hospital, that may be. No, that's a hotel. That is a hospital in Hopewell, New Jersey. So anyway, you can take the quiz. I think you'll find it amusing, if nothing else. But it's really kind of sad, and hospitals continue to build this way. Last week I did a conference with Craig Christensen of Harvard and said, what's going to happen with all this bricks and mortar in 10 years? And he said, it's not going to be used as a hospital anymore. Something will give, and I don't know what it is, but it won't work. So next time your hospital is talking about a new wing or an extension or a fountain or hiring another curator, maybe you can direct them elsewhere. This next story is about someone named Barb Benion who went in to get cataract surgery. She's 80, active, lives in Connecticut. And she went into a local ophthalmologist who offered her, which Medicare now permits, upgrades, like don't you want to upgrade to economy business, or don't you want to upgrade? It's that idea. The two upgrades she was offered, one was called a toric lens, which corrects for astigmatism. The second upgrade she was offered, and that was $1,500 an eye. The second upgrade she was offered was $3,000 for a laser scalpel. Now, Medicare pays somewhere around, I think, $1,500 for the whole surgery. So she was asked way more in upgrades than Medicare would have paid. And Medicare, doesn't pay extra for a laser scalpel, because all the research I've seen and that they've seen is that a regular scalpel works just fine. But lasers sound cool, right? And if you say to a patient, it's laser surgery, like my mom would go, yeah, I want that, So they offer these two upgrades. Toric lenses, I think the evidence is more mixed. They do help a lot of people with astigmatism rather than wear glasses, but that's only if you get the results that are desired. So anyway, she was offered both. She said to her ophthalmologist, what's better? And as she said, meaning better for my sight. I don't want to lose my eye. And he said, Oh, better is, both upgrades, which would have cost her $10,000. Barbara was lucky in that her daughter-in-law happens to be a nurse who works in an ophthalmologist's office, and that ophthalmologist said, laser surgery is nuts, don't do it. It doesn't make any difference. And so she said no to that upgrade. But when you look at the business of laser cataract surgery, which is what I started looking into for the book, because I wanted to know why are people offering this. When that machine came out for laser cataract surgery, people were like, why would anyone do this? It would only exist at hospitals. It's so expensive. You could never recoup, your investment. There's no ROI. But these companies are really clever. So what they did is to offer a portable laser surgery machine that ophthalmologists can now rent for a morning, and they get a click fee every time they use it, which they can transfer on to the patient. And these machines now come with books on how to use them medically, and also books that describe how often and how they can be used to recoup your return on investment. So now it is profitable, at least, if not medically desirable, for a lot of ophthalmologists to have these in their office. This is my beware of what you're offered. Next, I'm going to go after pharma briefly, and then we'll talk about things we can do. How many of you know about a drug called Duexis? Duexis, I heard about from a guy who was a controller for Dallas, and he said, I was just prescribed this drug called Duexis, and when I went to get it at the pharmacy, I noticed that it was being billed at over $2,000. What on earth is this? What is it? I thought. So I went and looked. What is Duexis? Well, it's a drug made by Horizon Pharmaceuticals. It's a combination of ibuprofen, known as Advil or Motrin, and famotidine, known as Pepcid, both of which are over the counter and pretty cheap. It is a higher dose of ibuprofen than the normal. We normally are 200 milligrams, but prescription strength is up to 800 milligrams, so you could just take 4. So I calculated what Duexis would cost. You could buy, 1,000 tablets of ibuprofen for $13.99, 50 of famotidine from $9.85. So 1 month's supply of each would add up to about $11. But Duexis, with a free coupon for 1 month, costs $2,319, $2,319. And it's a successful drug. That's the real miracle of this. No other country will license this drug, by the way. They'll say, this is, what are you talking about? This is nothing. It's nonsense. Well, what happens, and this is where I think physicians need to be much smarter. A detail person comes into the office and says, I've got this great new drug. And Horizon spent a lot of money hiring salesmen in the U.S. when they came up with this drug. What does the detail person say? I've got this great new drug, you want to give your patients high-dose ibuprofen, but that can upset their stomach. So you can tell them to take Pepcid, but we're just going to make it easy for them, and we're going to combine them into one pill. So all you have to do is write this script. The physician never asks, how much is this going to cost? Because they assume Motrin and Pepcid are cheap. How expensive could it possibly be? There's the answer. $2,000 expensive, and the insurer pays it most of the time. Okay. So to illustrate, I'm going back to one of my, let me see if I can get this to work. To illustrate the difference in what we pay for medicines here and elsewhere in the world, I created at the Times this graphic which we called Raining Pills. It was inspired by the fact that a patient in DC contacted me who needs to take Advair, and his strategy for purchasing Advair, which now costs over $200, closer to $300 in the US, is he flies to Paris each summer, buys 7 inhalers, and pays for his flight because Advair is so much cheaper there. So here's in the US, and these are manufacturers' suggested retail prices in different countries. This is not with insurance, National Health Service. These are manufacturers' suggested prices. Qvair, which is an asthma inhaler, 2 in the US, 37 in Greece. Rhinocort, 2 in the US, 51 in Romania. Augmentin, you know, a bee in my bonnet because of my kids and their ear infections, 19. And last of all, Colchris. This is a drug for gout, which was Now, the story of Colchris, and again, this is why we should all be thinking about FDA and what it does or doesn't do, is that it was something really, really cheap called colchicine. Until about 5 years ago, the FDA asked pharmaceutical firms, they made what was a smart request. There were some really, really old drugs, like colchicine, that had never been tested up to modern-day standards. So they said to industry, whoever is willing to test these drugs up to modern standards can get a 3-year exclusivity on that drug. You know, so a very smart company, you know, smart from a business point of view, took up the challenge. Guess what? Colchicine was fine, but they got to rebrand colchicine as Colchris and up the price by, I think it was 100 times. So anyway, now how come I'm not moving? Okay. Again, very quickly, this is pharmaceutical advertising, something that we are one of 2 countries in the world that allows. Anyone who watches CNN must wonder what is non-24. How many people have seen the ads for I am totally blind? I have a sleep-wake disorder called non-24. Non-24 is a sleep-wake disorder that affects people predominantly almost exclusively who are totally blind. That means there are about 70,000 at most people who experience this in the U.S. The drug is a drug that is a melatonin analog. You can't patent melatonin because it's a naturally occurring molecule, but you can patent a drug called Hetlioz, and you can try to get a whole lot of people on it. And it's not just, you wonder, like, really, you're doing an ad for those, you know, maybe 70,000 people who are totally blind who might be watching CNN every night? That doesn't make sense. So what's the game here, right? And the game is, I believe, although I'm not sure, what is Vanda testing non-24 for now? Jet lag. And I think there's a much bigger audience for that. What it doesn't say is that Hetlioz costs $8,000 a month. Again, why would anyone write that script? I would encourage every doctor to say no. But it is a profitable company, and it's a profitable drug. It shouldn't be. This is a woman named Wanda Wickizer who was uninsured. She had a subarachnoid hemorrhage, and unfortunately for her, 8 days before the ACA took effect, when she would have had insurance but didn't have it when she had her subarachnoid hemorrhage, was airlifted to University of Virginia Medical Center, who saved her life and charged her $356,000 as an uninsured person. They would have taken about $80,000 from Medicare, from the VA, but, you know, once again, the prices will rise to whatever the market will bear. She is still fighting the UVA, which tried to take her home and has done her tax payments. Actually, now she's lucky. She's remarried to a veteran and has TRICARE, so she's in good shape. Anyway, the stories are endless. The patients are angry, and they want a health system that will change, will deliver them good. They don't really care about the art on the wall. They don't know which scan is expensive and not expensive. They're not in a position to make those consumer choices, which we tell them, oh, you should be a good consumer, right? Hey, how could I buy blueberries at West Side Market if there was no price tag? And I didn't know if they were like fake or real or rotten or poison, you know? So I think it's really up to the system and to the employers who've mostly been asleep at the wheel to deliver a much, much, much better product and much, much better value, because I know for my 2 employers, both the Times, I mean, they would love to be giving people pay raises, but they can't because healthcare costs are rising so much. Ambulances, I bet most of you don't know that they are now the majority of ambulances are out of network, and they will bill like anything else. They used to be, in the 1960s, they were mostly hearses in many parts of the country, did ambulance bus rides. Then they were all volunteer. Now they're mostly venture capital owned. I had one patient named Kathleen Williams who was charged $1,000 for a minor ambulance ride, essentially across the street. They wouldn't back down. They wouldn't say no. It was out of every network in Ohio where she lives, and so she's now paying her bill because they have to set up a payment plan. She's now paying it $10 a month for the rest of her life. And she said it was the only thing I could do. Okay, last thing I wanted to show you, and then we'll talk about solutions really quickly because there are tons of them and you can read them in the book. This is a comparison of two hip operations, one in the US, and one, a guy who had insurance, but again, this was before Obamacare and shows the importance of pre-existing conditions. Mike Chopin had a bum hip because of a sailing injury many years ago, so he was insured, but it didn't cover his hip. So this is what he did. He went to Belgium for his surgery.
I needed a hip replacement, and I started looking into what it cost to have it done.
It came to
This is
$112,000.
Susan Foley, who had her hip replacement in San Francisco.
Total charges for the hospital.
I'd heard about having surgery overseas. Basically, the price was $13,660 for everything. The surgery, the rehab, the flight over and back, 2 people, crutches, medication to take home with me, everything.
This is not the prosthetic, this is not the anesthesiologist, this is not, anybody who actually did anything. This is just the hospital bill.
Total cost of hip surgery in Belgium, including everything, cost just about $600 to $700 more than the wholesale cost of just the prosthetic device in the United States.
The good thing about my knee surgery was getting my mobility back and getting my life back. And it enabled me to start horseback riding at 66, which most people don't start horseback riding at 66. And I couldn't be doing that without the joint replacement.
I bought a new board, new snowboard, new boots, all this stuff, because I'd given it up years before because I couldn't, and started riding again. I was pretty cautious for the first year just because I was scared of falling. But this past year, I taught 26 days on the mountain. I mean, I'm stronger than I've been in a decade.
Okay, so there's lots of room to move here. Okay, which is part of what the last thing I want to talk about. And we'll get into a lot of the solutions, and a lot of them are in the book. And my message is for everyone. I know people's first reaction is, well, it's not me, it's him. The problem is, it's not the hospital, it's the pharmaceutical person, and the pharmaceuticals, it's the PBM. And my message is, it's all of us, including patients. We all have to change the culture of medicine and what we think medicine looks like. Where Mike Chopin had his surgery in Belgium, one of the best hospitals in Belgium, lowest infection rates. He researched all of this, but it looks like an American junior high school. There is no art on the walls, or there's a poster or two, an old airline poster. So patients have to change. When people say to me, oh, I love that hospital, there's like free coffee in the lobby, it makes me berserk, because that coffee is not free. So what can we do? And I'll go through quickly. Some things are happening now. I think this is really, really good. I think we're at a moment where we're at a tipping point where things are so bad that we're starting to see motion, mostly at the state level, because states are closer to the people and closer to the people's pain. Having lived in D.C. for 10 months now, I can say a lot of people there don't know what's going on the ground and how painful this is. They know the numbers, but they don't hear from the people. So surprise billing laws, I want to say pros and cons, because I live in a state where there is a surprise billing law. I've been a beneficiary of it when I went to an ER close to my home and found out that all the ER doctors there are out of network. I think it's great that these exist. I resent that I had to fill out 3 forms and fax them to 3 different places to be absolved of my financial responsibility. And I want us to go back to our hospitals and say, if a patient comes to an in-network hospital, they will only be seen by in-network doctors or will only be charged in-network rates. That's what they assume when they come to an ER. And it's unfair to patients to kind of, to surprise, it's extortion right here. Once you're in the ER, you need to be seen. So I think that should be our get in the end. In the meantime, these surprise billing laws are great, and I don't know why medicine is the only place where fax machines are still in use in the world, but that's another question. The medical oath, another thing I discovered when I was, and I know I'm probably going to run 5 minutes over here, so apologies, I'll sign books really fast. Another thing I discovered when I was researching the book is a colleague of mine, a medical school classmate who's a surgeon in Miami, a wonderful guy, Michael Canning, sent me the fellowship pledge that he took when he became a member of the American College of Surgeons. And he was really surprised because one of the things that says in here is, I will set my fees commensurate with the services rendered. And he works at a public hospital. And I thought, wow, are doctors still signing this pledge? And, you know, most doctors don't control their fees anymore anyway. I discovered that that clause had been taken out of the American College of Surgeons pledge in about 2004, and a similar clause had been taken out of the AMA guidelines. So, you know, we need to get organized medicine back into thinking like doctors, not like finance people. I tell patients, these are things you should do. Whoops. Oh, I got to get back. Whoops. Where's my previous? Oh, sorry. I tell patients in the book, I give them 5 ways to save money in the hospital and 5 ways to save money in the doctor's office. You know, they can do it. I tell them not to make sure they don't get a private room, but you can do this for your patients too. I mean, how many people have I heard from who get an out-of-network or a supplemental private room charge? Because guess what? Hospitals build only private rooms now. So, but insurers don't see it that way. So I guess, you know, when I get bumped up to business class because economy is full, I don't want to be charged business class rates, and that's what's happening to patients right now. Avoid out-of-network charges, that's a big one. And when I sign those consent forms, and I hope everyone goes back to their hospital and does something about this, when I sign that pile of consent forms, I tell everyone to write, you know, I will be responsible for everything not covered by my insurer so long as it is in my insurance network. I want that to be a legal part of our contract, and it should be part of contract law. How to save money at the doctor's office. These are more patient tips, which you can read. This actually comes from Medium, but it's in the book too. Little things, you know, I want my lab sent to Quest or LabCorp, not sent to New York Presbyterian where my doctor practices, because I know labs at the hospital are marked up way, 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 way more. And his computer is set to order labs at the hospital, so I now go to him and ask him, I love my doctor, to fill out a requisition to send it to LabCorp or Quest. I mean, it's a pain in the ass for him and for me, but I think it's worth doing now to send these signals where and when we can that we're not going to put up with extortion anymore. And this is where I really want the doctors to step up to the plate. Engage and partner with your doctor on value. I don't know how to put this. I'm teaching my doctor to think about value in the sense of when I need this knee MRI, I want to be able to say to him, there are 20 places where I can get an MRI within 3 blocks of your office in Manhattan. So I want you to send me to the one that does a good job that charges the cheaper rate. And that will set off a chain reaction where he doesn't know. I know he has no idea. He knows which ones were in his class in medical school and which one will send him back results electronically. But I want his secretary to call around and start asking. And I want him to say to the guy who's charging $5,000 for an MRI, I'm not going to refer patients to you anymore because you're ripping off my patients and I don't like hearing about this. I want everyone to become a healthcare voter, an important thing. I want them to say, this is a little like my campaign of the future that I want to be involved in. Inaccurate insurance directories, like we don't have to wait for Washington to do something about that. I do not understand insurers who are in the audience, why those shouldn't be accurate the way Expedia and Travelocity are up to the minute. You know, what can I get now? I want insurance directories. I hear from a lot of people that they go to insurance directories. I mean, how many people have tried to find a doctor through an insurance directory? You know, and how many of them you have had success with that route? They're inaccurate. More than 40% of entries are inaccurate. This notion of in-network but not taking new patients, for me, that means you're not in my network. You know, that, as long as that person's not taking new patients, take them out. That's what the digitalization of the world is about. Every other industry has managed to do it, and healthcare can too. I want to know that provider networks are not just accurate, but adequate. And I want some definition of what adequate is. So far, we haven't seen that. I hear from too many patients who get injured in Connecticut and find out that the nearest orthopedist in network with availability who's taking new patients is in New Jersey. Okay, last of all, little proposal is, how about not letting doctors and hospitals go in and out of networks? How about keeping networks stable for the year of a contract? You know, I have a contract with Honda for my car I lease. It doesn't change in the middle of the year. And I think we shouldn't, you know, we as regulators, our insurance commissioners, I think really have to deal with this planned network situation. So this is, you know, voters say, what can we do? Find out who your state health commissioner is and start complaining. Unfortunately, as I discovered when I had a reporter look into this, many health commissioners do also things like be fire marshal and, you know, the state controller. So it's a tough job. But anyway. Employers, purchasers, asleep at the wheel, sorry. Why did the New York Times pay $10,000 or $9,000 for my colonoscopy? Why did Empire pay over $10,000 for Jeffrey Kivy's Remicade infusion? Why did Anthem pay $117,000, this is someone in the series, for Peter Dreyer's assistant surgeon? He had a spinal fusion. Oh, he had a spinal fusion that doesn't normally need one. So the surprising answer, or maybe not so surprising, is no one sees it as their mission. When I called the insurer to say, like, why did you pay these? Their answer is, well, you know, it's a lot of trouble to go after doctors and hospitals one by one. We need NYU in our insurance network. We can't really piss them off. And, you know, when I asked them about why did you pay Peter Dreyer's assistant surgeon, they said, well, you know, we don't have a contract with him. We'd have to take him to court. We'd have to assign investigators. It's easier to just pay. We have to stop taking the easy way out, I guess is the answer, and deal with it systemically rather than one-on-one when we get a complaint. In fact, when I spoke to the Blue Cross Blue Shield people, I'm sorry, it was at Anthem, and said, why did you pay this? Their last response was, gee, are you going to publish this? Because then other surgeons will know they can do it too. So, you know, the answer is don't pay. Like, wipe the graffiti off the subway car and tell people it doesn't work anymore. Some payer solutions that I think are practical, that I see coming up, that I would love to see deployed more widely, is reference pricing. CalPERS and Safeway in California tried to get an estimate, working with Jamie Robinson at Berkeley, got an estimate of what it would take to do a good, high-quality hip replacement in California. What was a reasonable charge? And they came up with somewhere around $40,000. And then they said to all their employees, that's what we're going to pay. If you go to a place that charges more, you're going to take on the difference, but your insurance will pay for it if you go to a place that charges less. So first of all, it gave their employees, first, they didn't go to the bottom dwellers, as everyone says, oh, you know, I want high quality. They went to high quality surgeons and hospitals. What they found, two things, is it gave their employees impetus to shop around, which was really great, but also a lot of the hospitals that, like Susan Foley's, that were charging over $100,000 for this procedure said, okay, we can do it for $40,000. So again, you know, the prices will rise to whatever the market will bear, and once the market stops bearing them, they will come down. A lot of hospitals, another version of this is bundled payments. You know, NYU did a test of bundled payments for hips and knees for CMS and found out that their results were just as good and that they could do it for much cheaper. What they found, which is interesting, and what was interesting about Mike Chopin, is he went home from Belgium after a week and didn't have rehab. Rehab and a lot of hip replacements is not necessary. Develop bulk contracts for labs and radiology and direct all employees there with no or low copayment. Make a deal with Quest or LabCorp. Don't send them to your local hospital. Maybe go back to that old world where you have an on-site doc once a week. The doc in the boxes are not very high quality. You could probably save a lot of money there. Longer-term insurance contracts. I would love to see some of these. You know, this narrative of every year you have to shop around, well, you know, that gives insurers not a lot of incentive to keep you healthy for the next 10 years. Maybe my insurance should last 5 years, give the insurers some incentive to really care about me losing weight. Real wellness programs. I've had wellness programs everywhere I've worked. They've mostly been nonsense, frankly, being very blunt. You know, they'll have a fair where they'll check blood pressure. The one good thing they did maybe was give flu shots. You know, flu shots are a good idea, but we were next door to a Duane Reade where we all could have gotten them anyway. VA Move is an interesting model. The VA, because they have patients long-term, patients gain 10 pounds and they get a notice, and people start getting involved in putting them in an exercise program. Bargain with some of your big local hospital systems. You know, one benefit of consolidation is you might be able to get everything in one place. I know Boeing has worked out an arrangement for all of its employees with one system in Washington State, and you know, basically I want hospitals to bargain, or employers to bargain, employers like Boeing to bargain as hard for their health care as they do for their jet engines. Demand good products and listen to your employees. Don't troubleshoot one by one. Our approach so far has been, you know, a patient complains, and every place, Kaiser Family Foundation, we have someone named Kathy Caserta, who everyone loves, who troubleshoots claims when people have problems. She is wonderful, but ultimately that doesn't change the system at all, at all. So insist on accurate provider directories, insist on longer terms of contract. We've talked about these other two. Engage your employees, survey your employees, not with Press Ganey scores, but ask them about how the plans are working for them. I mean, people tend to go to each other's desks and bitch about their health care, and so our employers don't find out how badly these are working. Share the results. Hold an enrollment panel with your employees to compare plans, especially capitated versus fee-for-service. Okay, and then I think, you know, there are a lot of things we see starting. One thing that I think is the first step in whatever health program we go to, a national health system we go to, is we need a lot more transparency in the system. We need to pressure labs, doctors, hospitals, pharma, PBNs for transparency, because whether it's going to be the employer negotiating rates or consumers having to do a little more on their own, how can you do that without knowing what the price is? You know, I often joke when I go into my local market, I don't have to crowdsource what the price of bread is, but that's what we have to do in healthcare. Now, so last of all, I think we're seeing some things happening within the last week. Maryland and California both have passed drug pricing regulations. I think we'll start seeing more and more at the state level, and I think this may be like gay marriage, where states act first and it ultimately coalesces into a national movement. But I want to point out with kudos to these two states, still how low the bar we're holding is. You know, California requires reporting and review of price increases that are greater than 16% every 2 years. I mean, if a drug goes up 16% every 2 years, we all end up bankrupt pretty quickly. But it's a start, and I think that's where we have to start with things like that, and we'll see where they take us. I know there have been bills for importation here in Maine. We're watching those too. So last of all, I like, you know, being a former environment reporter, I like to compare this to alternative energy, where I think you can either be ahead of the game or behind it. Things will change in 10 years. Things will not be different. There will be different payment models. Value, real value will matter. And you can be putting your head in the sand and thinking the old way is going to keep on keeping on, or you can be ahead of the game and be the first in healthcare, like people have been the first in alternative energy. You know, I'm still waiting for a hospital that puts out a sign to advertise, which would work, I think. No surprise charges, all insurance accepted. I'd go there. So thank you.